start. Okay. So everything is clear. I'm muting myself right now.
Okay, fantastic. So, Luca, you ready?
Yeah, I'm ready. Are you ready?
Yes. So this is going to be a rapid review of
All
a
right.
huge textbooks after textbooks. We'll review it in 1 hour. So, good morning, good afternoon, good evening, folks. I think most of them in Europe is good evening now. My name is Dave. They call me Dr. T. All my hundreds of students and mentees and around the world, they call me Dr. T. And with love and care, we have a blizzard outside in New Jersey. I'm talking to you from Monmouth County, the shores of New Jersey. And we have a severe blizzard, 1 foot of snow. I was just showing it earlier to Luca. We're going to quickly look at a dissection, just a little overview of the TMD, the so-called TMD. First of all, I hate that term, but that's all we have right now. Temporomandibular disorders. Some people write it as temporomandibular joint disorders. That is wrong. That is not the correct way. Okay. And in our upcoming course, we are going to dissect this way, way above this. Today we have 1 hour. We're going to use 150 hours to find out everything about, let's say, about head and neck pain. That's the power that we're going to give you. This is not important. This is I really don't care if you don't follow me or anything. We discuss cases in here. So I'll show it again, and some cases can be discussed there. No charge for that at all. So where do I come from? What did I do in this field that I think I can talk to a bunch of nice clinicians about pain? So I did my Bachelor of Dental Surgery, then New York University Doctor of Dental Surgery. I love general dentistry. I love aesthetics. I am not proficient enough as Luca is, but I did some beautiful work for 25 years along with facial pain. Then I saw some of the patients that I was in my practice that I bought new that were not getting better by this acrylic upper plate and lower plate. So I said, you know what? I don't know why don't they get better because my foundation in medicine is really good. I said, let me learn a little bit more. So I went to University of Florida. At that time, my first mentor, Dr. Henry Gramian, he was amazing. He was in University of Florida. So I flew to him every month to learn from him, okay? Mini residency. The more I learned, the more I begin to realize how much I don't know. You humble down. You say, Lord, I don't know this thing. So I then took a fellowship. I then took a master's from Rutgers, at that time, University of Medicine and Dentistry, New Jersey. The reason I'm showing you this is my perspective, where I come from. I'm not the one that took a 2-day course yesterday and coming to you saying, let me teach you. I did some homework. So this was a master's in facial pain. Then I took a master's from University of Sydney, Australia, in sleep medicine. And then I took another master's in headache facial pain, headache management from University of Edinburgh. Currently, I'm doing a PhD in pharmacogenetics and pharmacogenomics. The reason I'm telling you all this, I have a little bit of homework that I've done that makes me eligible to at least to talk to you, all these beautiful folks today joined. And the key to my success is my mentee students from around the world. Okay, they're represented from around the world. They are my strength. My students are my life, apart from my family, and then good friends like Luca. I met him really recently. It's not like long time. But you know what? The chemistry will click, and that means we can do wonders in life together. So, the anxiety and the fear of dentistry. Oh my God, my patient has TMD. What the heck is wrong with us? We dentists make a big deal out of this small little joint. Orthopedists deal with so many other joints except the TMJ because they say, that's dentists can do it. So, in my perspective, it's just another orthopedic joint. These people who make a big deal out of TM joint, I mean, I'm not that crazy. It's just another orthopedic joint following the same principles of other orthopedic joints in the body. So we're going to look at, and in our courses, we're going to make you strong with medicine in orthopedics. So let's learn some orthopedics, a little bit of rheumatology, a little bit of physiatry. What is physiatry? We didn't say psychiatry. We said physiatry. What is that? The science of muscles. That's it. Okay. Orthopedics is the science of joints, the science of muscles, and a little bit of physical therapy and stuff like that. That's all the TMD really needs. Okay. Please don't be scared about this so-called complex joint. We make a big freaking deal out of it. It's not so complex. Let me tell you, it's not so complex. We want to make it that way so people can sell products. I'm going to simplify it for you. It is rather simple. If you want to look at literature, we published this in Temporomandibular Disorders, very 17 chapters, only dealing with this is 2023, it's not so old. Please look at it. And then systemic factors that affect your dentistry and TMDs. That's my strength, medicine. Answers to current questions in dentistry, we just published. This is January, this month. Okay? Let's look at it. What I want to tell you is this. I'm not someone who took a 2-day course and I'm giving you, oh my God, now I'm the big guy. No. 25 years, I immersed myself in pain management. 25 years. I'm going to give you everything. Not because when I pass this earth, I want some people to follow the legacy that I think I would have made. So, in TMDs, temporomandibular disorders, not temporomandibular joint disorders, there's no such thing. Temporomandibular disorders, what are the components we should know? We should know the joint, the muscles, the ligaments. See, this is what programs don't tell you. What about the ligaments? Can they cause pain? Of course. Tendons? Of course. Does the TMJ have tendons? Multiple. The disc. What is so big about the disc? Can be displaced? Can be displaced with reduction, without reduction. No big deal. Simplify it. But now I have the question for you. What if the patient telling you is not really the source of the pain? The source of the pain, the source of the pain is different. It's from somewhere else. Are you and I equipped to find that out? That is my power. That's my challenge. That is what I'm going to give you. And you guys excel beyond me. I'll be thankful to Lord that I did something good and you're doing something better. So the bone, not a big deal. I'm not going to redundantly explain this. There is a glenoid fossa. There's a condyle. There's a little cornoid here. That's it. And there's some ligaments, tendons, some muscles attached to it. Well, is this exclusive to us? No. It's everywhere in the body. It's the same story. One thing I want to tell you, the biggest blunder in dentistry, we thought articulators represent the joint. They don't. They don't at all. Not even 10%. Not even the fully adjustable articulator. We learned it. I went to dental school first in 1987. Many of you were not born at that time, probably. 87. 40 years later, we still do this articulated circus. It does not represent the joint. It does not represent the joint. It represents everything else. I love your occlusion stuff. I love full mouth rehab. All those things I love. But when we think that the articulator can represent something like this, look at this. The condyles are not symmetric. They are turned medially, number one. They're not ball and sockets. They're not ball and sockets. They are like shaped like this, like an RBC here. You see the little depression here. Look at the torque on this thing. This is not even normal. It does not even remotely represented by the articulators. The moment we think articulators are really good for representing joint, we lost the bus, we lost the bus station, we lost the town that the station is there, we lost the district or the county that the town is there. We lost the case already. Okay? So your patient comes to you and says, oh, I have upper appliance, I have a lower plate, I have blah, whatever. And somebody did the arthrocentesis, washing of the joint. And somebody put me on medicines. And I still have joint pain. This is the case I want to see from you. Those cases that somebody did, let's say 3 plates, upper, lower, and some other plate, hard, whatever. Some medicines were tried. Then somebody said, oh, okay, let me put a hole here, let me wash it out. A big nonsense, many a times. And still complaints of joint pain. What do you do now? Well, I look at medicine. So what am I looking at? Your patient has problem in the TM joint. They're showing you right here. Where do you look for the information? I want us to be the physicians of the stomatognathic system. By the way, I'm an editor for Medical Clinics of North America, not dental clinics, that also I am. Medical Clinics of North America. What does that mean? Medical folks all over the US contracted me and said, can you do a textbook for us? I'm like, in what? Sleep medicine. I humbled down. And I'm telling you, if you learn the basics of sleep medicine, many of these circuses will disappear and we will become the physician of the stomatognathic system. Look at the differential diagnosis. So here's the patient who came to you after so many people have seen them of joint pain. Now the patient says, you know what, these dentists don't know what the hell they're doing. Let me go to my physician. The physician says, I don't know this. I'm going to send you to a rheumatologist. Now watch the miracle. Watch the marvel of medicine. The rheumatologist sees the same patient that was a TMJ case, and the rheumatologist says, what the hell is a TMJ case? I'm going to do some blood tests. This is their Bible. This is a busy slide. I don't care. You don't need to read this. What I want to impress upon you is the same case that you and I as dentists fail to diagnose goes to a rheumatologist. Does the rheumatologist look at the bite or the vertical dimension or this or that? No. They say, hey, you have joint pain? Let me look at it. And I'm going to tell you what the rheumatologist, this is my Bible. This is my Gita. This is my Quran. So differential diagnosis of joint pain. What do? I look at the causes of one joint pain, monoarticular. What does that mean? Not big, one joint. Or periarticular, around one joint. Hey, the TMJ is also a joint. So what did the rheumatologist do different from you and I looking for the bite, bruxism, the biggest circus in dentistry? What the hell is bruxism? We don't even know. 40 years of this I've seen. Nothing big has happened in 40 years. Let's take the medicine into our hands. Look at the rheumatologists. They want to rule out all of this for one joint pain. And I'm like looking at them and saying, what? And look at this one, differential diagnosis of polyarthritis. That means if two TM joints are involved and the neck is involved, I'm not looking at the bite. I'm not looking at the joint. I'm looking at a systemic thing that happened to this patient. It could be a virus, it could be bacterial, it could be a reactive arthritis. Since COVID, all of you know Europe has been hit hard with COVID. Post-COVID, rheumatic fever, primary arthritis. It goes on and on and on. What level have we grown? This is the biggest fallacy in dentistry. We look at a stupid articulator thinking that is like big representing the joint. It's not even 1%. But when we look at medicine, our eyes will open. Ignorance is gone. What the mind does not know, the eyes cannot see. Are we equipped is my challenge to ourselves. Next component, the muscles. If I ask some students, let's say there is a posterior temporalis. This is the posterior temporalis, not middle, not anterior. If I ask dental students, supposing the patient utilizes the posterior temporalis and clenching, where will this condyle move? I ask them. 85% of them have no clue. I would say 100%. This is a failure, right? This muscle is one component, two component, and three component. Let's say in Lucas, this is most active. My question to you is this. Think about this, okay? When both sides are activated, and in Lucas right now, the posterior temporalis is most active. Where will this condyle move? This condyle has to move upward and backward. Nobody taught us this way. That is why we failed in dentistry when it came to pain. And bilaterally, when the masseter acts, I asked 85% dental students, they got it wrong. This doesn't bring the condyles upward. This brings the condyles upward and forward. This is physiatry, the science of muscles. Are we equipped? This is Jeff Okeson, very, very good friend of ours. I know Lucas knows him very well. I'm not going to go through into any of these at all. I'm just showing you the complexity of the movements of the muscles. Please read up. Once you're thorough with this, you don't need to have any equipment to understand these cases. Nothing at all. Nothing at all. Orientation of the muscles, everything. In our courses, we're going to make sure you understand the orientation of these muscles. When you know the orientation, and when I ask you, how does the mandible move if my right medial pterygoid spasms? 99% of the dentists, no clue. That's why I'm giving them in a group, and I'm going to show them this diagram, and I'm going to tell them, if this muscle contracts, where is your condyle going to move? Medially. Where is this condyle going to move? Laterally. Why? Because TMJ is a ginglimo, meaning hinge axis, hinge movement like a window. Diarthroidal, two joints combined together. So if this muscle contracts and mediotrudes this one, this has to move laterally accordingly. Not rocket science. We're going to teach you in our courses. The other muscles, we have the neck muscles, so many of them. We're going to make sure you understand the palpation of these muscles, the pain referral patterns to the TM joint. You know how many blunders are committed because they don't know if it cannot be reproduced from the joint. What do you look for? You look for the referral patterns. I want us to be the medicine man, the physician of the stomatognathic system. What the mind does not know, the eyes cannot see. If we did not learn it, we're not going to see that. If I learned only occlusion, I'm going to only see occlusion. If I learned occlusion in muscle, I'll see occlusion in muscle and recognize it. Let's take it beyond that. Let's take it to the physician's level. How many of us knew that the masseter, we said superficial, we said deep. How many of us knew that the masseter has three components? Not in this diagram. It's not in this diagram. It's just, this is it. And the deep masseter is shown here. This is new. Are we equipped? This is 2022. So through 2022 to 2025, we know that masseter has a third component. I asked this to dentists. 100% of them did not know this. What level have we grown in diagnosing and treating TMD cases? Zero, many times. Zero. That's a failure. So this is the masseter with three components now, right? Look at that third component, folks. There is a masseteric component that is attached to the coronoid. So Dr. Lucas and I, we are publishing on the coronoid enlargement case, hypertrophy, right? Case. But look at this. This is the component of masseter which we did not know 5 years ago. We did not know this component 5 years ago. And we think we know everything about TMD and occlusion. No, we don't. We don't. We're still learning. We are little babies. And I want you to be proud of that people that learn medicine. Now, your patient had 3 appliances, arthrocentesis. Somebody said, let me wash your joint. There are groups of people who say, let's wash the joint. Do you have a diagnosis is what I asked them. Why you want to wash the joint? Why want to puncture this area and wash the joint? Do you have a diagnosis? If you go to the cardiologist and you complain about chest pain, and the cardiologist says it could be heart or it could be gas, right? Intestinal gas or heart. Okay, what are you going to do? Let me explore the heart. No. You will say, are you crazy? You want to go into my heart and see if it's gas? No. Why is it different in dentistry? Because we made fools out of ourselves in TMDs. Okay. What do you do if the patient has 3 appliances, washing of the joint, drugs in the system because they want to be pain-free, and still complaints of muscle pain? You know where I look? I don't look at dentistry. These books behind me, Upper half is dentistry, lower half is medicine. This is not a virtual one because I want to read medicine. And what does medicine dictate me? Medicine says if you have muscle pain, where do you look? You look at medicine. This is the mechanism of muscle pain. Nobody taught us this way. This is why I have 13 classes finished, 1 year, 150-hour programs in India. We are going on our 14th program. Why? Because people have seen muscle ischemia is the reason for muscle pain, not bruxism and this and that. Come on, this nonsense. Come on. It's not that. It's muscle ischemia. That's medicine. So then, what causes ischemia of the muscles? Oh my Lord. Look at the rheumatology textbook. What a beauty. Rheumatology 10th edition. It's a 2,300-page book. I have it down there. And when I'm looking at medicine, then you can know polymyalgia rheumatica, systemic vasculitis, hepatitis C, Lyme disease, HIV, neuropathic pain, multiple sclerosis, fibromyalgia, myofascial pain, joint hypermobility. Are we equipped to do any of these? If we are not, what business do we have to look at this patient with TMD? The rheumatologist doesn't look at the occlusion or just how the teeth were lost. He says, I don't care. I'm going to look at your blood and your plasma and your cerebrospinal fluid and your muscles and your nerve conduction. Why is it different when it came to dentistry? This is a failure. So I will teach you, along with Dr. Lucas and other folks in our programs, medicine of pain. And this is what it is. Now, the ligaments. So we've covered the bone, we covered the muscle, ligaments. 99% of the program don't dare to talk about the ligaments. I will, because I did my research over 25 years to talk to you about ligaments. This is called ligamental pain. So the first question is, what is the function of ligaments? This morning they wrote down in the chat box to support the jaw. No. One answer in medicine. Ligaments are the limiting structures of the joint. Limiting structures of the joint. What does that mean? They limit the joint movement. They limit the range of movement of the joints. If a patient is hypermobile, excess mobility, laxed, and I am there on the other end, are we going to be the same? No. Then why are we doing about this bite and this and that and bruxism, all this nonsense? Let's look at the ligaments in medicine. What do we find? Look at the beauty. This is from Jeff Okerson's textbook. Here's a temporomandibular ligament. Look at the beauty of the diagram. I told Jeff, what a beauty you did. Not any other textbook has this. Maybe Lucas's textbook coming out will be probably same or better than this. I have a feeling. My question, my challenge to you is this. Let's assume that there is, okay, first of all, ligaments are limiting joint movement. I asked my students around the world, what movement of this condyle does this ligament limit? In other words, if that ligament is okay and it limits joint movements, what movement? Is it upper movement, forward movement, backward movement, downward movement? And the answer is simple. Look at this ligament attached and wrapped around this. Primarily, this will limit the backward movement of the condyle. How beautiful if you learn medicine. Now assume that you have a hypermobile kid or hypermobile young person, hypermobile individual in your chair, complaining about ear pain and joint pain, and he's hypermobile. Do you think this ligament is going to limit and be so functional? No. What will it do? It will allow further movement backwards, posteriorly. What is behind the condyle? Retrodiscal tissue. What is so beautiful about the retrodiscal tissue? Filled with blood, filled with nerves. You think this patient is going to be happy? No. Look at this. I'm just exemplifying it. I'll teach you all of this in detail in the course. But look at this ligament, capsular ligament. What a beauty. It looks like a circus tent, okay, around the condyle. Now I'm asking you the question. What movement of this condyle does this ligament primarily limit? And they're scratching their heads. 99% of dentists, no clue. I don't know. Forward, no. Backward, no. Upward, no. You can move upward. When you said downward, you got the answer. Why? This condyle comes downward. This ligament is going to say, no, 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 no. I'm going to hold you in position because I am your limiting structure. Now, consider a hypermobile individual. Is that going to be the same? No. Consider an animal that does not have this. That animal is a snake. Does not have this. How can he open the mouth? Like this, vertically. Because it's not good. See, this is beautiful. Medicine is beautiful. I love it. And that is what I've given hundreds and hundreds of students around the world. We're going to come to Gdansk and we're going to teach you this. Yes? Limiting structures are the ligaments. Yes? What a beauty. And look at this. If this condyle, for some reason, moves backward and upward here, it has to compress this tissue. Is this rocket science? No. You know what the dentist said over the years? Oh, I'm going to put a mandibular replacement device, an advancing device. What? Where is the physics in it? A single plate of plastic sitting on the lower teeth or upper teeth that I adjusted in the patient's chair, 45-degree angle, and I'm telling the patient, there is no sense of physics. All BS. And BS does not stand for Bachelor of Science. It stands for something else. All right? So, what is the predictable way of positioning this jaw forward, thereby relieving this tissue? I need to attach it to the maxilla. That's the physics. What am I talking about? Sleep appliances, mandibular advancement device. How beautiful medicine is if you combine the physiology and the physics of it. Otherwise, same damn thing we are taught, and what the mind does not know, the eyes cannot see. Ligaments are the anchors of our joint. The mandible, this is the mandible, is attached and limited by these ligaments. I lecture on a lot of cruises. This is what I see. The moment the ship docks, they connect it to with the little ropes, which are our ligaments. So let us learn the medicine of ligaments. What is the mandible? What is the TMJ? It's a puppet show, folks. It's a puppet show. You cannot predict. Oh, some people tell me, oh, if the medial pterygoid contracts, the mandible is going to move this way always. No, it's not. No, it's not. On both the sides, there are 5 ligaments, 5 or more tendons, and muscles, 5 or more muscles. And the inferior muscles are different, right? So this thing, mandible, is a puppet show. You cannot predict that. A lot of dentistry is written upon this type of nonsense. So let's learn medicine, right? For example, in the American dental boards, they ask, which is the ligament that we injure almost a lot of times when we do an inferior alveolar or mandibular nerve block? You know which one? The sphenomandibular ligament. This is right there where we inject. 90% of the cases, poking that ligament, staring it, no problem. They'll have a little pain and they're okay. Is that the same case with every case? No. Are we equipped to understand ligaments? And what happens if the ligaments get torn or affected or are hypermobile? We're going to learn it together. Source of ligamental pain. What a beauty. This is the sphenomandibular ligament. Why is there this? Why did nature give us a stylomandibular? And this is not even correct. The stylomandibular ligament is attached like this many cases. That's a limiting structure. As you're trying to protrude the jaw, the with the inferior lateral pterygoid, the stylomandibular ligament says, I'm not going to allow you to go that forward. I'm going to limit your movement. So what happens to the mandible? It tries to go forward, but then it ends up in opening like an R. Ligaments are the limiting structures of the joint movement. What a beauty medicine is. The tendons. Yeah? Temporalis tendon. You know, these cases I get, I feel bad for them. They have been treated. I have cases from Romania, I have cases from US, from India, but all these cases have been treated by stupid teeth adjustments and plates and bruxism treatment, all this nonsense. And when we go inside the mouth, within 2 minutes, 2 minutes, you have a I love the belows. We have a diagnosis. What is it? The coronoid process attached to the temporal tendon. If that is inflamed and painful, every time the patient yawns, chews, opens, they'll have pain. It's not TMD. I mean, it can be classified as TMD. I don't care. Are we equipped to diagnose this? That is what we want to teach you. And then I look at medicine. What is the source of tendon pathologies? There are certain medications, antibiotics that we can give. The one that called fluoroquinones or fluoroquinolones. They're all tendon problematic. You know, gives for upper respiratory infection, upper respiratory, lung infection. They all damage the ligaments and the tendons. Are we equipped? Do we know this? Learn medicine, please. The disc. I ask my students, hundreds of them, why is the disc there? They say it's cushioning. They say it's there, blah, 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 blah. Why is the disc there? One reason I can give you. Without the disc, there's going to be bone to bone contact. I'm going to give you medicine. If the bone to bone contact in the human body, if one bone contacts the other one without a separating medium, remember in prosthodontics we said separating medium. Couple of things happens. Number one bone becomes antigenic to the other bone. They don't like each other. Okay? So some cells in here and here start destroying each other. That's it. That's why you have ligament. I mean, that's why disc. The disc is like a bullseye, a sunny side up, a mushroom. Wherever this bone goes, the ligament has to follow. I mean, the disc has to follow. Simple thing. We make a big deal out of it. Oh, ligament. No, it's a disc. It's everywhere in the body. If there is no disc, such as in the cranial sutures, two bones connected together, no disc, they fuse. Uh-huh. Can that happen in the TMJ? Yeah. In the rib to the sternum, costochondral. Okay, costochondral joint. There is no disc. So what happens? They fuse. Fibrous fusion. How beautiful medicine is. Please learn medicine. Okay, it's so weird what happens in dentistry. That is why physicians look at us and laugh. Let's stop that laughter. Let's say we know the stomatognathing system. We are the physicians of the stomatognathing system. I'm very passionate about this. We are the physicians. We are the MDs of the stomatognathing system. Don't teach us that. We will teach you, the physician. Please know your panoramic. This panoramic doesn't even show the joint. This is what one dentist did in the God-given USA. So many countries are not different either. There's no joint in here. They want to diagnose TMD. All nonsense. And then CBCT. This is another circus. Patient has jaw pain, CBCT. Justify your imaging. CBCT is also X-rays. Panoramic is also X-rays. A patient coming to me when I do my lectures my exams for my students, and they say patient came with pain in the cheek here, and I took a panoramic, they failed. Why did you irradiate the patient with ionizing radiation when you know that the pain was right here? No reason. Panoramic is the most distorted film ever. Look at this thing. Most distorted film ever. Why would you take a panoramic routinely? No reason at all. It's a scout film if you suspect something. If not, don't irradiate the patient. If my mother is on the chair, I don't want to irradiate her unnecessarily. And I hope we take that to heart for our patients. Why is this different? We must justify our imaging. And then if I suspect something in the joint, okay, do a CBCT. Why not? But justify your imaging. This is what they don't teach us in dental schools. Horrible. justify imaging. The management for TMDs, we need a differential diagnosis. I missed something here. We need an evolving diagnosis, evolving. Sometimes these are evolving, and that's okay. And then we need an actual diagnosis. That is our strength. Is it the joint? Is it the muscle? Is it the tendon? Is it the ligament? Is it the disc? Can the disc cause pain? Not the center of the disc. The periphery can cause pain. Do we know that? Is it a combination of these different things? Maybe. Are you equipped? Can we teach you? That's why I'm coming to dance to teach you. Identify the modifying systemic factor, man. This is the MD. This is the physician of the stomatognathic system. Are we ready to identify it? Do we know the blood test to do it? If you do, we won the case already. What is your short-term and long-term therapy and goals? Can we do that? Is it the biopsychosocial model? Biology, psychology, social. Now, haven't you seen people saying this is psychogenic case? You know how many psychogenic cases I have seen since I took it upon myself to learn medicine? Zero. Zero psychogenic cases. 99%, you're sitting with the patient and the assistant, 3 people, and you think it's a psychogenic. If I think it's a psychogenic, the only psycho in the room is me. Patient is normal, assistant is also normal. I am the psycho in the room because I don't have the knowledge. I'm ignorant. I'm the blind person. So I said to Lord, give me wisdom to see through this case. There is no such thing in my dictionary as psychogenic. There is no such thing as psychogenic. I want to come to the bottom of this and dissect my case and have a diagnosis. So if you have a diagnosis of psychogenic pain, bring it to Dr. Lucas, bring it to me. Let's dissect the case. I'm challenging myself. Yes. Manage psychosocial comorbidities. Of course, they can be depressed. Who is not depressed if you have pain for 3 years, 5 years, 10 years, 20 years? You think you will not be depressed? Yeah, but that's not the depression causing the pain. I'm depressed because of my pain and my inability of my dumb physicians, including dentists, that could not recognize my pain. Of course, that gives you anxiety, psychosis, and I'm anxious, and I look like psychogenic pain, but I am not the psycho in the room. The patient says, let's empower ourselves. Patient's participation, empathy. This is amazing. This is the biggest circus. I mean, look at this nonsense, man. Bruxism is the biggest circus in medicine. 1987, folks, I went to dental school first in India, the best dental school in India. India is 1.4 billion people. I went to Manipal, very proud Manipal graduate. Manipal is a city in India, South India, best dental school. 87, when we had a Bruxa case, we put one of these junky little plastic plates in, either on the lower or on the upper. Look at this nonsense literature that has come out over the last 40 years. Bruxism, this, Bruxism, that, this thing, that thing, this thing. In the end, fast forward 40 years almost. We are in 2026 now. Let's say 2027, right? 40 years. And somebody comes to me in 2026. Guess what I do for the Bruxism case? Upper plate, lower plate, and maybe if I'm so good at this, Botox. What else? It's cognitive behavior therapy. Basically, we are stuck in this 40 freaking years. Nothing happened. Nothing good happened in this Bruxism thing. All these publications, one quoting the other, cross-quoting it, and they go in circles. And what happened? Look at the circus happening all around the world. Did we change anything? And you know what? You look at American Academy of Sleep Medicine with all this literature that has apparently come out, American Academy of Sleep Medicine's classification, ICSD, International Classification of Sleep Disorders. Guess what? Sleep-related bruxism is classified as what? Movement disorder. Uh-oh. All this literature for what? For me and you as a clinician, we want to know, I have a 15-year-old child that is grinding the hell out of the teeth. What can I do? Oh, then I'm going to tell you, oh, I have a systematic review with meta-analysis. I don't care. Parent says, I want my child to stop bruxing. Can you do that? Answer is no. We can talk about comorbidities, all this nonsense. I like medical comorbidities, but this is the biggest circus that happened in dentistry. One of the biggest circuses, apart from centric relation. So we publish robustly. And I invite you to publish with us. Bring us a topic. We will do the topic. We will do the best we can, and we're going to publish robustly. We did occlusal splint. This is not a small little thing, okay? I don't care about systematic review, meta-analysis, systematic review of systematic reviews, meta-analysis of systematic reviews. And in the end, 40 years I looked at, 4 decades. In the end of all those dumb reviews, they say what? We need more studies and we need more controls. Then why didn't you do that and do it to begin with? I'm a clinician, and 99% of my students are clinicians. They want to know, how can we treat this? Is there a management for this? That is my power I'm going to give you. And that is the power we're going to research and study together. Please look at this publication. Occlusive splints, what is the evidence? Evidence. We looked at 300 years of literature, and we're going to plus. And I made my student, who is amazing postgraduate, as the first author. I said, you are done so well. So please look at it. I'm researching this with Dr. Lucas Lassman. Let's look at deprogrammers. Look at this. Look at deprogrammer. What are you deprogramming? I want to see medicine of deprogramming, right? Look at that. Occlusal splints. Nothing. You can put whatever the hell you want, basically. And then this paper came out. I like this paper by Gary Classer, amazing paper. And Chuck Green, amazing paper. What can appliances do? What can they do not do? This is can, and this is cannot. We're going to go through this paper in our course, okay? So my peeve, systemic factors. Yes, medicine in pain. So we published, right? Systemic factors in temporomandibular point. Now we're talking. Okay, let me tell you what are the comorbidities of TMD: headache, low back pain, myofascial pain, anxiety, depression, fibromyalgia, irritable bowel syndrome, chronic fatigue syndrome, stomach pain, really? Vulvodynia for females, vaginal pain, sleep disorders. This is medicine. Are we equipped? And we still publish this with my chair, Dr. Steven Singer. What are the comorbidities, right? We need to look at this type of papers to see sleep disorders as related to TMDs. Look at hypermobility. Are we equipped to understand if your patient is hypermobile? I'll teach you what are the comorbidities these patients have. Our eyes open to medicine, we are successful. And then this type of papers have come out. What a beauty, huh? Sleep bruxism associated with vitamin D deficiency, low calcium, anxiety, depression. It can even have higher cardiovascular risk. I love this type of medicine. This is what I want to see. Nature and science of sleep, nature. But we don't talk about it. We talk about this publication, that publication. Why? Let's look at medicine. And whatever I know, I'll teach you. And then you can excel in it. Now your patient has TMJ muscle pain. Where do you look? Be the physician of the stomachokinetic system. Physician, not the plate trimmer. Look at vitamin D, ubiquitous, everywhere. In the cell, you need vitamin D everywhere. You need vitamin D. How can it be possible that with vitamin low D, is it possible for us to be normal? And then we look at today is the blizzard here. There's no sunlight at all. Am I going to be normal with no vitamin D? I don't think so. Look at medicine, folks. Can you see this? How many, and 90% of them are associated with pain. Are you and I equipped for TMDs? TMDs, trash, TMD, temporomandibular disorder. I mean, orthopedists don't call it knee disorder, hip disorder, ankle disorder, wrist disorder. They call it with this diagnosis. We have some classification, RDC TMD, DC TMD. What the hell? What does it help clinicians? Nothing. So we're going to do the clinician aspect of this, hopefully, in our course. What the mind does not know, your eyes will never see. If I don't know something called a pencil, this is some type of a weapon for me. I don't know. But the mind does not know, the eyes cannot see. Look at my myalgia protocol. We published it 5, 6 times already. This is what I'm going to give you when we teach you. If there is joint pain, muscle pain, ligament pain, tendon pain, joint and muscle pain, any combinations, I want us to do this because this is what medicine has taught us. This is what orthopedics, rheumatology, neurology, neuroscience, pain management taught us. Why were you looking at something different? Forget the grinding. We're going to look at this in our courses. This was from the attendee from Romania. I forget his name, and he's fantastic. I asked him for permission to look at this, right? Systemic factors are this entire glacier below this. And what are you seeing and I seeing? Not even this. We're seeing this tip. That's it. The so-called TMD tip. The so-called bruxism tip. What the hell? Conclusions. We need TMJ biomechanics and pathology. We're going to learn it. We need to learn medicine, okay? Not a mechanic. TMJ is not a complex joint. Don't let them scare the hell out of you saying it. We can treat it. We can manage it. We can probably prevent it. And this is my handle, and you can do that. I'm going to share a screen. Hopefully, remember, real knowledge makes you humble. The real knowledge guy. The little bit knowledge guy walks around like this. I cannot bend my head because I'm so big in science. No. What the mind does not know, your eyes will never see. That's not just in TMD, any education. If you don't have it here, you're not. However, last part, ignorance of this, not an excuse. We need to learn. And that is why we are coming to Poland along with Dr. Lucas Lassman. I know he's a good man. That's why I trimmed up with him. I don't need another course in my life. I want this course in my life. We are so good in Middle East and India. I got booked completely for my course for June start, already booked up. And I closed my admissions. 25 people maximum, because I teach them 101. I will teach you. I will not let any stone unturned. I will not cover up anything. I'll give you everything, what I learned from behind me, what is there. That's medicine of pain. I will teach you that. I hope I see you there. Look, if you can either share screen, or maybe I'll share. I want to show that what is our proposal here for the people. Let me see if I have it. If I don't have it, then it's okay. Let me see if I can share it.
I see.
1 second.
You can check if you can share the screen. In the meantime, I see one question. What about the use
Yes.
of protective post-rehabilitation splints after form of rehabilitation? It is claimed that it will keep the muscle relaxed to reduce complications of bruxism.
Okay. The only thing it does, 2 things I'm going to tell you. Clear. Very good question. I love the question. Very good question. What is the end literature on this, right? You put any plate, upper, lower, double plate, single plate, soft plate, hard plate, anterior plate, posterior plate, whatever plate we want, we are comfortable, who taught us. It reduces the strength of contraction. Watch what I'm doing. I'm clenching, and the frequency of contraction, how many times I do it. Good? It reduces it. The question is how long? 3 to 6 weeks. Uh, what happens after that? You happily grind ever after. It's like a happy marriage. There's no white story. Happily grinding ever after. Okay. So what do? Let them grind. So what is really the so-called appliance, plate, reposition, whatever? What is it doing? Protects the teeth, of course. If I do full mouth rehab, I did it for 25 years. I took 300 hours of implants to do this. I took all the aesthetic courses. I want my teeth and my investment in the patient and the patient's investment in the full mouth rehab protected. So what will I do? Put the plate in and I tell the patient, this is going to protect your teeth. Dr. Thomas, how long am I going to wear it? I tell her, listen, I have hypercholesterol. I'm on Lipitor, okay? Lipid medication. How long am I going to take lipid medication? For life? Yeah, that's right. So if you stop grinding, I'm happy for you. I don't know why you stop grinding. We don't have the literature for that. But until then, if a patient has invested her money and time, or his money and time, in that full mouth or 2 teeth or 2 crowns, you protect it, nothing else. But scientifically, we're going to discuss this. And my peeve is medicine. Are there medical issues that can show up as the so-called bruxism? That I will teach you. And I'll
Yeah,
teach
there
you
is
to
also
best I can.
one more. There is also one more aspect because people very often ask me, uh, do all of my patients after full mouth reconstruction they get the night guard? So the thing is that whenever you do the full mouth reconstruction, you have to know why you even do this, because probably the
Yes.
patient has a tooth wear, right? You don't do the full mouth
Yeah.
reconstruction for people with beautiful teeth. So if they have already destroyed their teeth, and you know that the bruxism does not come from occlusion, but from, we still don't know where from,
We
the
don't know.
central pattern
40 years, man.
generator,
40 years.
serotonin,
Oh, nonsense, man.
dopamine, everything. Maybe from the guts, maybe from the gut
Maybe from the
microbiome.
foot,
So,
even the
so you,
footnail.
yeah, so you will not stop bruxism with an appliance. And when I hear that when you do the good occlusion, you don't need a night guard because the best
Mm,
stabilizer is the good bite, what kind of nonsense is this, right? So also important thing is that if you have the inside out movement of the lower teeth against the upper teeth, if you don't put the upper night guard, you will have spacing between the teeth after 2 3 years,
that's right.
maybe even earlier. And since most of our patients, I hope that probably most of our patients in your countries as well, go through ortho before prosto, which is very often required. You also need the
Yes.
stabilization for the teeth. So the night guard will not stop bruxism. The night guard will protect the teeth, the structure of the
Absolutely
teeth,
right.
I mean the ceramics, and the position of the teeth, right? So don't listen to people who tell you that the night guard after full mouth reconstruction is unnecessary, because if you are a good dentist, you don't need the night guard. Jesus Christ. And also
All
important
right.
thing is that you have to know if your patient has a sleep apnea, because with the night guard
Yes.
and increasing VDO, you can worsen the sleep apnea. So now we have a patient
Okay.
with a bigger bruxism, bigger sleep apnea,
Very
grinding
true.
more, destroying everything, and a vicious cycle.
Yeah, see,
Right?
that's our strength. We're going to talk about medicine, medicine of dentistry, not the voodoo. In my hands, it worked. Who the hell cares? If I'm telling you guys, there's 100 people on board right now, that coconut oil, 2 drops on the head worked for me. Are you going to do the same? No. Why? Because there's no study, there's no prospective studies, there's no controls. I'm a crazy guy. No, that's not
There's
medicine.
there's
Medicine
the one
is
comment. There's one comment. So instead of an appliance, a night guard should be worn. Guys, what do you mean? Instead of appliance, a night guard is an appliance. So whatever you
Luca,
put
ask him
between
to
the
join
teeth,
the course. Well, let's teach them.
yeah, but
It's the whole idea.
so the piece
It's
of
good.
plastic between the teeth is an appliance. The programmer is an appliance. What does it even mean that the programmer? It's just a piece of plastic that you put between the teeth that could potentially relax some muscles and probably do nothing to the brain. At
I
least
love
we
the
don't know
questions,
because
by the way, because that
yeah,
is what happens in dentistry. People just indoctrinate our poor dentists to believe into this type of occlusion, this type of that. And then when I see them, I'm like, you lost your mind in medicine. I'm so sorry. Let's look at orthopedics. Let's look at physiatry, neuroscience, neurology. I'm going to make you trim into this, and then you will see, oh my God, I see the wisdom. You want to do an upper appliance in appropriate case, do the upper appliance. You want to do lower, do the lower. But I'll tell you, if you do both upper and lower, it can treat ADD, we say. And then the patients ask me, what? Attention deficit? No. Acrylic deficiency disease. Because if you have upper and lower and you grind on the acrylic and you swallow it, you that was a joke. You will not be deficient in acrylic. That's going to be. So I'm sorry. The medicine we're going to learn, we're going to teach together. Bring up all these questions. We're going to discuss. No question is beyond our science. So this is
I see
good.
one more comment. I think they mean the use of splint that place joints in CR instead of arbitrary. Oh my God, we are confusing in here too many aspects because when you do the full mouth reconstruction, you should do it rather in CR when you reorganize both arches. If you do the night guard, probably you will also do it in a CR because if you don't do it in CR, you have a different position of the jaw at night and different in the morning. So probably we should maintain the same position at night and in the
Yes.
during the day.
Absolutely.
But
Luca, let's have another component of this in our program. I didn't include this yet. Let's have full mouth rehab, like we have done the textbook, FMR and TMD and stuff in combination. Let's do that also. We'll
we can
discuss
we
it also
can
for
we can
them.
do it.
Yeah. And there's a question for bruxism. Do you advocate sleep study in every case? Not at all. Not at all. See, bruxism nowadays, we all grind our teeth, either during day, during the night, or both. But if I screen the mouth for obstructive sleep apnea, or the patient is giving you signs and symptoms of central sleep apnea. So there are two. We'll teach you central and obstructive. Bruxism, who wants to do a sleep study? However, in the Bruxer case, if you have signs and symptoms that are consistent with OSA, and you can have Mallampati score, you can have the lateral border of the tongue scalloped, you can have linea alba bucca, narrow arch palate, soft palate being slipping down, patient is tired during the day, simple things. Of course, then we do sleep study because bruxism is nothing. I told you this nonsense bruxism thing for 40 years. What did I do in 1987? Nothing different from what I do right now. Plate upper, plate lower, if I can. Then maybe I'm so good with Allergan, then I inject some Botox. But after 3 months, what? Again, Botox. It's not going to stop. So we're going to discuss that medicine part. But however, I showed you the studies that shows bruxism with increased cardiovascular risk. That type of study, I want to see more. Otherwise, it's just one quoting the other quoting this quoting this. And we have like 200 publications on bruxism with absolute no use for clinician. Publication is okay. I love publication too. What do you and I, there are 100 people who joined today, what do we want to do to manage these cases? That's what we're going to look at. Luca,
We
with your
want to do the
permission,
blood test. We want to do the blood test, and
yes,
I think that the big strength of this program, the fellowship, will be that we'll have the on-site because we have enough online workshops around the world, and after some online courses, I see people don't even know how to palpate the muscles and how to palpate the joint, how to search for the trigger points, how to examine the nerves, because they don't even know
absolutely
how
right.
how strong should they push the tissues. So we need to
Yes,
see each other on the spot, on in our venue.
on site, folks, on site. Okay. We're going to see on site. I'm 101. More than like 30 people, I will not probably end up in taking only because I'm going to really engage us as mentor mentee, and then with Luca and other people that I'm going to bring in from around the world that are medicine men, not some philosophy men, medicine men. We're going to teach you the medicine of this thing, and I'm proud of it. because this has been now 10 years since I opened up these programs. We're going to come to Europe. Pharmacology, for example, we're going to make you swim in pharmacology. It's a very volatile thing. We can make medications work for our very, not always, but we can make it work for our cases. And then the modules that is on site. I'm going to hold your hand. I'm going to make you palpate every muscle, reproduce that pain, reproduce that pain. There is not one course like this in Europe. There is in Dubai, Middle East, there is in India. US, we teach anyway. Europe, this will be the only singular course, I can tell you, that I've envisioned like this with Lucas. So I invite you to join. You can discuss with Luca and his team. Jacob will be there and his team will be there. You can engage them, see what you can do. But I'm telling you, you will be happy and thankful that you joined a course like this, because I commit to this. It's not just like I teach and go. No.
I will be the participant with you guys. I also want to learn what Davis is
Cool.
talking about.
No problem.
So yeah, I've the blood test
This is our
and all these
course.
diseases that I also at the university I really hated rheumatology and immunology and all
We're
these
going to make it
things.
interesting, man. We're going to make
Yeah,
it
so
interesting.
now we have to learn again
It's a
because
new learning.
we don't want to play ping pong with endocrinologists, with rheumatologists and so on, because I'm sending the patient to my endocrinologist because they have some markers, the
Yeah.
autoimmunological
Yeah.
antibodies
We're going to,
to the thyroid, and they have a destructed joint, and the endocrinologist sends the patient back saying this is because of bruxism.
I
The idiopathic condylar resorption, half of the condyles is already dissolved because of
go.
the bruxism. Yeah,
No,
so
no.
this is what we are facing
Bruxism, the biggest circus
in
in
the regular
dentistry, man.
practice.
Let's forget bruxism. Let's take medicine, okay? I'm going to teach them medicine that
Yep.
they will have. Already people have joined, but I'm telling you, those of you on the fence, join the program and learn it to the fullest. 150 hours, but I'm going to give you like 200 to 300 hours, because it's also entry to our other programs, remember. Our 100-hour program with the pioneers from around the world, everything is going to be involved. Rapid review. So,
Maybe
Luca, if we are ready for the
the
batch, I'm
last
going to let them access. Yeah, yeah, go ahead.
the last webinar will be before the fellowship will be on 1st February, right?
Uh,
As
Jacob, you
far
can
as
just
as
confirm
I
it.
On
see.
the 1st February will be next.
1st February, the same hour. And that's going to
12,
be the
12
last
o'clock, right?
webinar in this. Yep. Yep,
All
yep, yep.
right.
And then we
This is it.
start with the fellowship in I think we will start at the beginning of April with the webinars. It's going to be every week and it's going to be
Yes.
pre-recorded. I mean, it's going to be recorded during the
Yes.
live,
Here we go.
and then you will
Yeah,
be able to see it after the webinar, because I know that many people are just busy on Sunday, so you will be able to
that's
watch
okay.
it whenever you want. That's going to be probably about 50 hours. So every Sunday, 1 hour, maybe 1 hour, a little bit more, right, Davis? And
Yes,
then
yes.
then all the rest will be on site. But on site we start in June, right?
That's right.
So yep.
We're going to have a firing lightning session. That's it.
Okay.
That I've done to almost 400 students from India, Middle East, and US. I'm going to come to Europe. This is it with you. Jacob, thank you so much.
Thank
Luca,
you.
any other
Thank you
questions?
very much. Guys, thank you very
Okay,
much for attendance.
fantastic
And
results.
hopefully see you the 1st of February. And then
Yes.
hopefully we will see you also in our fellowship. All right. Take
There
care,
you go.
guys.
Look at the fireworks. Show your kids,
I
okay?
cannot
Next
do
time
this.
too.
I cannot do this. I have to
There's
activate
something wrong
something.
with your Mac, man. That's what
There
it
is
is.
something wrong. Yeah.
All right, guys. Jacob, have a great evening. Luca, take care.
Have a
Once the
good
batch is
evening,
full, I'm
Thank
going
you
to
very
guys.
start
much.
right away. Okay? All right.
All right.
Take care, folks. Bye. Good
Thank
weekend.
you. Bye bye.